Hello, and welcome back to another chapter of Advanced Pharmacology. Today we're talking about Chapter 66, Drugs for Weight Loss. In the United States, 69.2% of adults are considered overweight. Of these, 35.9% are considered obese. Excessive, excessive body fat may be associated with increased risk for morbidity from hypertension, coronary artery disease, ischemic stroke, type 2 diabetes, gallbladder disease, liver disease, kidney stones, osteoarthritis, sleep apnea, dementia, and certain cancers. Among women, obesity may increase the risk for menstrual irregularities, amenorrhea, and polycystic ovary syndrome. During pregnancy, obesity may increase the risk for morbidity and mortality for both mother and child. In young men, obesity may reduce the quality and quantity of sperm. The Center for Disease Control and Prevention, the CDC, estimates that 112,000 Americans die per year from obesity-associated illnesses. Pediatric obesity is a special concern. Despite recent decline in obesity prevalence, almost one-third of American children and adolescents are overweight and/or obese. This increases the risk for hypertension, heart disease, and asthma. In addition, type 2 diabetes, formerly seen almost exclusively in adults, has increased tenfold among children and teens, and gallbladder disease has tripled. Obesity is now viewed as a chronic disease, much like hypertension and diabetes. Despite intensive research, the underlying cause remains incompletely understood. Contributing factors include genetics, metabolism, and appetite regulation, along with environmental, psychosocial, and cultural factors. Although obese people can lose weight, the tendency to regain weight cannot be eliminated. Put another way, obesity cannot be cured. Accordingly, for most patients, lifelong management is indicated. So, assessment of weight-related health risks. Health risk is determined by 1. The degree of obesity, 2. The pattern of fat distribution, and 3. The presence of obesity-related diseases or cardiovascular risk factors. Accordingly, all three factors must be assessed when establishing a treatment plan. Bringing us to BMI, or body mass index, which is derived from a patient's weight and height, is a simple way to estimate body fat content, and studies indicate a close correlation between a BMI and a total body fat. They can be calculated manually or by using an application. There's a link here at this website where you can try and assess the BMI. The following table that assigns BMI according to height and weight are also available here in this figure. So if you're interested in learning your own BMI, here's how you can do it. And then here is a BMI chart considering your height and then your weight, and then it'll trigger where you fall in terms of your BMI. So, for instance, if I was 5'11 and weigh about 210 pounds, I would be anywhere between that light green and medium green. So, I fall into the overweight/obese category. According to federal guidelines, a BMI of 30 or higher indicates obesity. Individuals with a BMI of 25 to 29.9 are considered overweight, but not obese. There is evidence that the risk for cardiovascular disease and other disorders rises when the BMI exceeds 25. These associations between a BMI and health risk do not apply to older adults, growing children, or women who are pregnant or lactating, nor do they apply to the competitive athletes or bodybuilders who are heavy because of muscle mass rather than excess fat. Your waist circumference. Waist circumference is an indicator for abdominal fat content, an independent risk factor for obesity-related diseases. Accumulation of fat in the upper body, and especially within the abdominal cavity, poses a greater risk to health than does accumulation of fat in the lower body, the hips and thighs. People with too much abdominal fat are at increased risk for insulin resistance, diabetes, hypertension, coronary atherosclerosis, ischemic strokes, and dementia. Fat distribution can be estimated simply by looking in the mirror. An apple shape indicates too much abdominal fat, whereas a pear shape indicates fat on the hips and thighs. Measurement of the waist circumference provides a quantitative estimate of abdominal fat. A waist circumference exceeding 40 inches in men or 35 inches in women signifies an increased risk in their health, but only for people with a BMI between 25 and 34.9. Your risk status. Overall, weight-related health risk is determined by BMI, WC, and the presence of weight-related diseases and cardiovascular risk factors. Certain weight-related diseases, established coronary health disease or heart disease, other atherosclerotic diseases, type 2 diabetes, and sleep apnea, confer a risk for complications and mortality. Other weight-related diseases, gynecologic abnormalities, osteoarthritis, gallstones, and stress incontinence, confer less risk. Cardiovascular risk factors, your smoking, hypertension, your high levels of low-density lipoprotein or LDL, cholesterol, low levels of high-density lipoprotein, your HDL cholesterol, high fasting glucose, a family history of premature coronary heart disease, physical inactivity, and advancing age all confer a high risk when three or more of these factors are present. Health risk rises as your BMI gets larger. In addition, the risk is increased by the presence of an excessive WC, or waist circumference. The risk is further increased by weight-related diseases and cardiovascular risk factors. In the absence of an excessive waist circumference and other risk factors, health risk is minimal with a BMI below 25 and relatively low with a BMI below 30. Conversely, a BMI of 30 or more indicates significant risk. In the presence of an excessive waist circumference, health risk is high for all individuals with a BMI above a 25. So, looking at the overview of obesity treatment, therefore, the strategy for losing weight is simple. Take in fewer calories per day than are burned. Of course, implementation is much more challenging. The key components of weight loss programs are diet and exercise. Drugs and other measures are employed only as adjuncts. So who should be treated? According to the federal guidelines, weight loss therapy is indicated for people with any of the following: a BMI of 30 or more, a BMI of 25 to 29.9 plus two risk factors, or a waist circumference greater than 40 inches in men or greater than 35 inches in women, plus two risk factors. So the benefits of treatment. In overweight and obese people, weight reduction may confer these benefits: reduction of high blood pressure in patients with hypertension, improvement of blood lipid status, so the elevation of the HDL cholesterol and the reduction of the LDL cholesterol, total cholesterol, and triglycerides, reduction in development of type 2 diabetes, and in patients with type 2 diabetes, the reduction of elevated blood glucose, and then overall, the reduced mortality. The treatment goal. The goal of treatment is to promote and maintain weight loss. The initial objective is to reduce weight by 10% over 6 months. For patients with a BMI of 27 to 35, this can usually be achieved by reducing energy intake by 300 to 500 calories per day, which should allow for the loss of about half a pound to a pound per week, or 13 to 26 pounds in 6 months. People with a BMI above 35 require greater caloric restrictions, between 500 and 1,000 calories per day, to lose 10% of their weight in 6 months. After 6 months, the goal of all patients is to prevent lost weight from returning. This may be accomplished by a combination of diet, physical activity, and behavioral therapy. If appropriate, additional weight reduction can be attempted. Although these goals are laudable and a return to normal BMI is desired, this is rarely achieved in obese individuals, even with drug therapy. A realistic goal is to target a percentage of body weight at which the risk is decreased and comorbidities are prevented. A weight loss of 10 to 15% is typical for those who are diligently adhering to medication and lifestyle regimen, whereas a loss greater than 15% is considered exceptional. Treatment modalities. Weight loss can be accomplished with 5 treatment modalities: caloric restriction, physical activity, behavioral therapy, drug therapy, and surgery. For any individual, the treatment mode is determined by the degree of obesity and personal preference. Caloric restriction. A reduced caloric diet is central to any weight loss program. As noted, the only way to lose weight is to take in fewer calories than are burned. Depending on the individual, the caloric deficit should range from 300 to 1,000 calories a day. Because fats contain more calories than other carbohydrates or proteins on an ounces for ounce basis, reducing dietary fat is the easiest way to reduce caloric intake. To succeed at losing weight, it helps to know just how many calories are taken in each day and how many you burn. The following websites here, which are free, have a database on food and physical activities, along with tools to calculate and log calories taken in and burned. So you can look at Choose My Plate or Super Tracker, free websites. Exercise. Physical activity should be a component of all weight loss and weight maintenance programs. Exercise makes a modest contribution to weight loss by increasing energy expenditure. In addition, exercise can help reduce abdominal fat, increase cardiorespiratory fitness, and maintain weight once loss has occurred. According to the American College of Sports Medicine, people trying to lose weight should exercise at least 150 minutes per week, and preferably more. And those trying to maintain weight loss should exercise anywhere between 200 to 300 minutes per week. Behavioral modifications. Behavioral therapy is directed at modifying eating and exercise habits. As such, behavioral therapy can strengthen a program of diet and exercise. Techniques of behavioral therapy include self-monitoring of eating and exercise habits, stress management, and stimulus control. There is no evidence that any of one of these techniques is superior to others. So, with stress management, they're talking about the stress that can trigger eating, and for stimulus control, limiting exposure to stimuli that would promote eating. Drug therapy. In theory, drugs can promote weight loss in 3 ways. They can suppress appetite, reduce absorption of nutrients, or increase metabolic rate. Drugs can be used in an adjunct to diet and exercise, but only for people at increased health risk, and only after a 6-month program of diet and exercise has failed already. Drugs should never be used alone. Rather, they should be part of a comprehensive weight reduction program, one that includes exercise, behavior modification, and a reduced caloric diet. Drugs should be reserved for patients whose BMI is 30 or greater, or 27 or greater in the presence of additional health risk factors. Drugs are not appropriate for patients whose BMI is relatively low. Drugs are also not appropriate for women who are pregnant. The American College of Obstetricians and Gynecologists recommends weight gain, not loss, for obese women who are pregnant, although the total amount of gain is less than that of a woman who is within normal limits for their weight. Benefits of drugs are usually modest. Weight loss attributable to drugs generally ranges between 4.5 pounds to 22 pounds, although some people lose significantly more. As a rule, most weight loss occurs during the first 6 months of treatment. Duration of therapy varies depending on the drug selected. Today, long-term treatment is recommended more often than in the past because we now know that when drugs are discontinued, most patients regain lost weight. Accordingly, when treatment has been effective and well tolerated, it may need to continue indefinitely. Unfortunately, not all drugs are approved for long-term use. Not everyone responds to drugs, so regular assessment is required. Patients should not lose or should lose at least 4 pounds during the first 4 weeks of drug treatment. If this initial response is absent, further drug use should be questioned. For patients who do not respond, ongoing assessment must show that the drug is effective at maintaining weight loss and serious adverse effects are absent. Otherwise, drug therapy should cease. Bariatric surgery. Surgical procedures can produce significant weight loss by reducing food intake. However, they are indicated only for patients with a BMI of 40 or more in the absence of severe comorbidities. The two most widely used procedures are the gastric bypass surgery, the Roux and Y procedure, and a laparoscopic implantation of an adjustable gastric band, which reduces the effective volume of the upper portion of the stomach. Surgery has been known to be effective. In 6 months to a year, patients can lose between 110 to 220 pounds. Unfortunately, the surgery can carry significant risk. In one study, mortality rates at 30 days, 90 days, and 1 year after gastric surgery were between 2, 2.8, and 4.6%, respectively. So, what are some weight loss drugs? As previously mentioned, weight loss drugs vary in their ability to promote weight loss. The combination drug topiramate and phentermine is associated with the greatest amount of weight loss, greater than 5% of body weight. This is followed by phentermine as a monotherapy and another combination drug, naltrexone and bupropion, which generally achieve a weight loss of greater than 3 to 5%. Orlistat provides at least weight loss to 2 to 3%. The individual classes of weight loss drugs are discussed next. Dosages and administration guidelines are summarized here in this following table, which again is a wonderful spot to hit pause so you can familiarize yourself with the different types of drugs. So, for instance, your lipase inhibitors, such as your orlistat, or your serotonin 5-HT2C receptor antagonist, lorcaserin. Then you also have your sympathomimetics, your dithilopropion, your phentermine, as well as your glucagon-like peptide 1 agonists, liraglutide, and again the combo drugs. So here is a good spot to hit pause. So let's talk about the lipase inhibitors, your orlistat, its action and use. Orlistat, or ALI, or Cinecal, is a novel drug approved for promoting and maintaining weight loss in obese patients 12 years and older. Unlike most other weight loss drugs, which act in the brain to curb appetite, orlistat acts in the GI tract to reduce the absorption of fat. Specifically, the drug acts in the stomach and small intestine to cause irreversible inhibition of gastric and pancreatic lipases, enzymes that break down the triglycerides into monoglycerides and free fatty acids. If triglycerides are not broken down, they can't be absorbed. In patients taking orlistat, absorption of dietary fat is reduced by about 30%. Patients must adopt a reduced caloric diet in which 30% of calories come from fat. In clinical trials, orlistat produced modest benefit. Patients treated for 2 years lost an average of 19 pounds compared with the 12 pounds for those taking a placebo. In addition, treatment reduced total and LDL cholesterol, as well as raised HDL cholesterol, reducing fasting blood glucose and lowered systolic and diastolic blood pressure. So what kind of adverse effects do they cause then? The gastrointestinal effect. Orlistat undergoes less than 1% absorption, and hence the systemic effects are absent. In contrast, GI effects are very common. Roughly 30 to 40% of patients experience oily rectal leakage, fat or flatulence with discharge, fecal urgency, and fatty or oily stools. Another 10% experience an increased defecation and fecal incontinence. All of these are the result of the reduced fat absorption, and all can be minimized by reducing fat intake. Dosing with psilocybin or metamucil, a bulk-forming laxative, can greatly reduce these GI effects. The underlying mechanism is the absorption of the dietary fat by metamucil. Possible liver damage. Orlistat has been associated with rare cases of severe liver damage. Signs and symptoms include itching, vomiting, jaundice, anorexia, fatigue, dark urine, and light-colored stools. Patients who experience these signs and symptoms should report them immediately, and orlistat should be discontinued until the liver injury has been ruled out. There's also been other adverse effects. Rarely, orlistat has been associated with acute pancreatitis as well as kidney stones, although a causal relationship has not been established. Cholelithiasis may occur if weight loss is substantial. Its contraindications, therefore. Orlistat is contraindicated for patients with malabsorption syndrome or cholestasis. Drug and nutrient interactions, the reduced absorption of your vitamins. By reducing fat absorption, orlistat can reduce absorption of fat-soluble vitamins, such as your A, D, E, and K. Vitamin K deficiency can intensify the effects of warfarin, an anticoagulant. In patients taking warfarin, anticoagulant effects should be monitored more closely. To avoid deficiency, patients should take a daily multivitamin supplement, and administration should be done 2 hours before or 2 hours after taking orlistat. Other drug interactions. Orlistat may cause hypothyroidism in patients taking levothyroxine by decreasing the absorption of the thyroid hormone. To minimize this effect, levothyroxine and orlistat should be administered at least 4 hours apart. Orlistat also can reduce absorption of cyclosporin, at least 3 hours into the recommended between doses of these two drugs. That brings us to the next medication, the serotonin receptor agonist, lorcaserin. Lorcaserin, also known as Belvic, is a selective type 2C serotonin agonist with indication for chronic weight loss. It suppresses appetite and creates a sense of satiety by activating the hypothalamic and mesolimbic pathways that control appetite. Studies have demonstrated an average loss of 5.8% of their baseline weight after 1 year, compared with a 2.2 in patients taking a placebo. In addition, Belvic reduces waist circumference, fasting glucose, insulin, total cholesterol, LDL cholesterol, and your triglycerides. But it does come with adverse effects. 10% or more of patients will experience a headache, back pain, and a decrease in lymphocytes and upper respiratory infections. About 30% of patients with diabetes will experience an increase in hypoglycemic episodes. Less common but serious adverse effects also include blood dyscrasias, cognitive impairment, psychiatric disorders, priapism, pulmonary hypertension, and valvular heart disease. Accordingly, this drug should not be given to patients at risk for these conditions. Lorcaserin has potential for abuse. It is classified as a Schedule IV drug under the Controlled Substance Act. It is also contraindicated. There are lifespan associated contraindications with this drug. So here again is an excellent spot to hit pause so you can read why there are considerations or concerns in different age groups. Certain drug interactions. Lorcaserin is an inhibitor of the CYP2D6 isoenzyme of cytochrome P450. When given with a CYP2D6 substrates, so drugs metabolized by that isoenzyme, the serum levels of the substrates can be increased. To decrease the risk for toxicity, when both drugs are prescribed, the substrate may need to be prescribed at a lower dose. Risk for serotonin syndrome is associated with serotonergic drugs. When serotonergic drugs such as lorcaserin is given with other drugs, the risk increases. We do not yet have sufficient studies to evaluate the effects of prescribing lorcaserin with specific serotonergic drugs, Therefore, caution and close monitoring is advised when administering this drug alone with bupropion, dextromethorphan, monoamine oxidase inhibitors, your serotonin norepinephrine reuptake inhibitors, selective serotonin reuptake inhibitors, St. John's wort, and triptans. That brings us to the sympathomimetic amines. So the dithylpropion and phentermine. The sympathomimetics fall into two groups, amphetamines and non-amphetamines. The amphetamines are not FDA approved for weight loss because they have a high abuse potential, so they are not addressed here. For noradrenergic drugs are approved for weight loss. However, only two, dithylpropion, the generic, and phentermine, should be used. The other two, the benzphetamine and phendimetrazine, have a higher potential for abuse. So, what are their actions and use? Both dithylpropion and phentermine promote weight loss by decreasing appetite. They are a central nervous system stimulant that suppresses appetite by increasing the availability of norepinephrine at the receptors in the brain. This same mechanism underlies the stimulant effect and potential for abuse. Weight loss is usually modest, about 7 to 8 pounds. These drugs should only be used in short term, so for 3 months or less. And they do come with adverse side effects. Like the amphetamines, both medications can increase alertness, decrease fatigue, and induce nervousness and insomnia. Because they interfere with sleep, these drugs should be administered no later than 4 p.m. After drug withdrawal, fatigue and depression may replace CNS stimulation. Both medications, the dithylpropion and phentermine, have effects in the periphery as well as in the CNS. Peripheral effects of greatest concern include tachycardia, anginal pain, and hypertension. Accordingly, these drugs should be used with caution in patients who have cardiovascular disease. Although the risk for abuse is lower than with the amphetamines, abuse can still occur. Both medications are regulated under Schedule 4 of the CSA. Tolerance is common and may be seen in 6 to 12 weeks. If tolerance starts to develop, the appropriate response is to discontinue the drug rather than increase the dosage. So it does also come with contraindications. Contraindications are associated with the development across the lifespan. Again, see the box for patient-centered care across the lifespan. That brings us to the glucagon-like peptide 1 agonists, liraglutide. Its actions and use. Liraglutide is a glucagon-like peptide 1 agonist that is approved for chronic weight management in adults. It acts by slowing gastric emptying, which increases a feeling of fullness, which leads to decreased food intake. Your GLP-1 agonists are also used in the management of type 2 diabetes to enhance glycemic control. In this regard, it also increases insulin secretion and decreases glucagon secretion, which means there are some adverse side effects. More than a third of patients taking liraglutide experience an increase in heart rate from 10 to 20 beats per minute from baseline. Roughly 1 in 20 will develop tachycardia. Other common adverse effects include nausea, vomiting, and either constipation or diarrhea. Hypoglycemia is a concern if taken by patients with diabetes who are taking other anti-diabetic drugs. However, this is a rare occurrence in patients who do not have diabetes. Headaches may occur, as may generalized fatigue and weakness, although again, these symptoms are less common. Because of the effects of gastric emptying, dyspepsia and abdominal discomfort may occur. Liraglutide is administered subcutaneously, as with any injection. Local site reactions, such as redness or pruritus, may occur. Several uncommon effects warranting special precautions occur in less than 1% of patients taking liraglutide. These include acute pancreatitis, renal impairment, acute gallbladder disease, So, so that means there are contraindications then. Liraglutide is known to cause thyroid cancer development in rodents, so caution is used and is warranted until the effects on humans are fully known. Liraglutide is contraindicated in patients who have multiple endocrine neoplasia syndrome, type 2, or who have a personal or family history of medullary thyroid carcinomas, which means there is a big black box warning. For liraglutide is associated with the risk of thyroid C-cell tumors based on studies in rodents. It is contraindicated in patients who have multiple neoplasia syndrome type 2 or a personal family member or family history of medullary thyroid carcinoma. So the lifespan associated contraindications are provided with the box for patients in the care center across the lifespan. Certain drug interactions as well. Liraglutide may potentiate the hypoglycemic effects of drugs given for glycemic control in diabetes. Additionally, it will enhance the glucose lowering side effects of other drugs with this feature, so including androgens, fluoroquinolone antibiotics, MAOI inhibitors, and SSRIs or selective serotonin reuptake inhibitors. Combination products. There are currently 2 combination products that are approved for weight loss. Each combination is unique with different mechanisms of action and different side effects. So, the first is the phentermine topiramate, a combination product, also known as Quizimia, is a Schedule IV drug indicated for chronic weight loss therapy. Phentermine, as mentioned previously, is a sympathomimetic amine, already approved for short-term management of obesity. Topiramate is currently approved for seizure disorder, which we'll discuss more in Chapter 19, and the prophylaxis of migraine, which is going to get discussed in Chapter 23. Phentermine suppresses appetite, and topiramate induces the sense of satiety. Possible mechanisms for topiramate include antagonism of glutamate, the modulation of receptors for gamma-aminobutyric acid, and the inhibition of carbonic anhydrase. In a 56-week trial, phentermine topiramate produced a 10% reduction in weight and a significant decrease in systolic blood pressure. The long-term results, however, are still not available, meaning there could be a potential for adverse effects. The most common effects were dry mouth, constipation, altered taste, nausea, blurred vision, dizziness, insomnia, and numbness and tingling in the limbs. The most serious effects are memory impairment, difficulty concentrating, hypertension and tachycardia, birth defects, acute myopia, with angle closure glaucoma, acidosis, and for patients who take insulin, secretagogus or insulin, an increased risk for hypoglycemia, beyond that of anti-diabetic drugs alone. So, there clearly will be contraindications. Again, these are more discussed in the patient-centered care across the lifespan box. Its use is also contraindicated for patients with glaucoma or hyperthyroidism. So, drug interactions. This combo drug should not be given with any kind of MAOI inhibitors. In fact, at least 2 weeks should pass before taking a MAOI inhibitor before phentermine topiramate is begun. Similarly, at least 2 weeks should pass after ending phentermine topiramate before a MAOI inhibitor is begun. This combo drug can potentiate CNS depressants. When given with the anti-epileptic drugs carbamazepine or phenytoin, levels of topiramate may be increased. The administration of carbonic anhydrase inhibitors increases the risk for metabolic acidosis, whereas the administration of diuretics that are not potassium sparing increase the risk for hypokalemia. Finally, studies show that concomitant administration with oral contraceptives increase the estrogen level while decreasing the progestin level, Which brings us to the other combo drug, naltrexone bupropion. So, the anorexiant naltrexone bupropion, also known as Contrave, combines the effects of dopamine and norepinephrine reuptake inhibitors with an opioid antagonist. The mechanism of action by this drug combination promotes weight loss is unknown, but it has been hypothesized that it acts on the regulation of the appetite in the hypothalamus and on the mesolimbic dopamine system, which is the key reward pathway in the brain. The individual drugs are discussed separately in Chapter 22 for naltrexone and Chapter 25 for bupropion. Adverse effects. The most common adverse reactions are nausea, vomiting, constipation, headache, dizziness, and insomnia. About 5% of patients experience an increase in blood pressure, dry mouth, diarrhea, abdominal discomfort, anxiety, and fatigue. There also is a suicide risk associated with this drug, meaning there should be a big black box warning on naltrexone and bupropion. The combination is associated with an increased risk for suicidal ideation and suicide attempts in children, adolescents, and young adults, which means there's contraindications. This product is contraindicated, again, for patients taking other products containing bupropion. Because naltrexone is an opioid antagonist, it will decrease the ability of opioid analgesics to relieve pain, so it should not be taken within 2 weeks of any kind of MAOI inhibitors. There's an additional black box warning. When the combination drug is given to patients who are taking or discontinuing bupropion, so aplensin, budepion, bupropion, Wellbutrin, or Cyban, severe neuropsychiatric reactions, including depression, mania, psychosis, and again, the homicidal ideation have occurred. Naltrexone bupropion are also contraindicated for people with selected conditions. It should not be used for weight loss in patients with uncontrolled hypertension, seizure disorders, or eating disorders such as anorexia or bulimia. Patients who are undergoing alcohol, barbiturates, or benzodiazepine withdrawal should not take this medicine. Again, the lifespan associated contraindications are listed in the box, which is why it was so important for us to hit pause there. Certain drug interactions. Drug interactions are numerous and reflect interactions of the individual agent. Again, Chapter 22 for naltrexone and Chapter 25 for bupropion. Dangerous interactions occur with MAOI inhibitors and opioid antagonists. We can't stress this enough, that's why it's mentioned so many times. The bupropion component of naltrexone bupropion is a minor substrate of numerous hepatic enzyme families and major substrates of the CYP2B6 enzyme. Inhibitors of these enzymes can increase naltrexone bupropion levels, requiring a lowered dosage. When CYP2B6 inducers are given with this drug, it may result in subtherapeutic doses. The combo drug is also a strong inhibitor of CYP2D6 enzymes. Accordingly, when given with CYP2D6 substrates, the combo drugs may increase those drug levels. Please note that regarding drugs for weight loss drugs share a disturbing history. They receive regulatory approval, undergo widespread use, and then are withdrawn owing to the discovery of serious adverse effects. It is quite likely that new drugs may be approved by the time you read this chapter. It is also possible that drugs in this chapter, especially those most recently approved, are already removed back off the market. Which completes this chapter. I'll see you all with the next chapter. Till then, thank you and goodbye.